Hello, can you hear me? This is Achim Gass speaking from Mannheim, Heidelberg University in Germany, and I have been asked to give you a current overview about the use of MRI in the management and diagnosis of multiple sclerosis. As you may be aware, multiple sclerosis is a very frequent disease in neurology, and I'm aware I'm presenting at an internal medicine conference, so I hope there will be many interested internal medicine specialists who take the opportunity to listen into those developments. Fortunately, we have quite a number of treatments available, and by the use of MRI, we are in the position to individualize or personalize treatment much better than in many other areas of neurological diseases. I want to thank the sponsors, Roche, for supporting this symposium, and I also would like to mention that their large phase 3 trials and their phase 4 programs and extension trials have led to quite an advancement of our scientific knowledge about the dynamics of MS, about important MRI features of progression, for example, that I will come to later in my talk. And this is a very nice example for both successful introduction of a new treatment, as well as advancement of our knowledge in the use of MRI. I want to move my slides. Okay. So these are my disclosures, and with this I go right into the NIDA, which is no evidence of disease activity. So this is a term that is used if you want to go beyond the clinical features of a disease, and you can see in the green boxes the clinical features of MS, but there is much more. And in the yellow you can see that focal MRI activity is seen as subclinical relapses, which originally is a clinical definition, but if you see a focal spot of inflammation on MRI, then this is evidence of disease activity. There are other biomarkers, for example, serum neurofilament levels, which are very interesting, telling you about loss of brain tissue matrix, and this should be very low in successful treatment, and we just started using this also for individual patients. What we will be looking at for the diagnosis of MS, MRI is of high importance and an integral part, but you will see that it is an integral part of our clinical work as well. So you really need to be knowledgeable or work in a team of a radiologist and a clinical neurologist. We can also see that in monitoring we understand which therapies are successful and where there is still room for improvement, and where we should possibly change the therapy or become much more alert how the control of the disease activity is working. And I will bring closer to you those features very soon. This is just to demonstrate to you that coming from a clinical perspective, we have these terms of aggressive disease and highly active disease, but you can see already there we use it all the time, not only when we do the diagnostic testing for MS, but also for the clinical categorizations, we use MRIs in integral parts. So just to base your assessment on the clinical features is not enough nowadays, also particularly as all the labels of the medications that we are working with integrate the features of MRI of disease activity seen from this perspective. It is very important that there is input from both sides, the radiological as well as the neurological side. This is a small abstract coming from Ireland where they investigated this feature systematically, and they could see that in joint radiological neurological conferences, or at least conversations, you get a much better understanding and much better output from your MRI investigation. I will show you now typical features of MS lesions. They should be ovoid, larger than just punctate. They have typical locations, periventricular, juxtacortical, infratentorial, around the aqueduct, in the optic nerve, involving partial cross-section of the spinal cord, many times involving fascicular brainstem fibers, the medial longitudinal fasciculars, but also cortical lesions. Many times they are perivenular, and this can be seen on SWI images, and they are much more asymmetric than microangiopathy. On T1 weighted images, you can see the variable degree of tissue destruction, and contrast enhancement is a highly specific and frequent feature. This is an image I want to show all the neurologists to provide them with some information they can use when they speak to their radiologist. Flare images, and you see two such images here, are very sensitive to flow, and you can see flow phenomena inside the ventricles on the left-hand side. And these flow phenomena translate into these cloudy features that you may mistake for lesion. If you want to speak to your radiologist next time, this is something you can use, where he will listen very carefully and say, oh, this neurologist knows quite a lot about MRI apparently, because when you ask, could this be a flow artifact, if you look at a lesion, then this will exactly this purpose. Here you see next to each other a proton density weighted and a T1 weighted image, and on the T1 weighted image you can see different degrees of hypointensity. And the lesion that is the darkest has the strongest tissue matrix destruction, while there are many lesions that are show very mild changes. So this is both important to see the severity of the tissue destruction, as it can be helpful for the differential diagnosis occasion. This is a patient who had an EDSS of 2.5, which is not such a severe clinical situation at the time when you had the scan, but you can see there are many very abnormal features. For example, the third ventricle is too big. You can see the pyramidal tract is involved, both temporal lobes and hippocampi are involved. So, as well as the corpus callosum is too thin, so you have features of many lesions, as well as brain atrophy. But at the time, this patient was still coping pretty well, because most of his lesions were supratentorial. On the T1 weighted image, you can also see that there are quite a lot of hypointensity lesions, giving you even more information that there's not only atrophy, widespread disease, but also very severe lesions in some places. And this provides you immediately with a prognostic view of this situation. And indeed, this patient became much worse over the coming years. And this kind of background information, particularly in the beginning of the disease, is very informative to build your own profile where you think this patient may go in the next years, but also what you want to achieve with your treatment. This image shows you cortical lesions with a special technique that not only darkens the CSF within the ventricles, but also makes the regular white matter dark. Only the lesions and lesions within the cortex shine out, and this is one way to visualize the smaller cortical lesions. If you have cortical lesions, and if you find cortical lesions in your patients, they are a larger burden and have been shown to that patients with cortical lesions are much earlier prone to progression than patients without cortical lesions. So our brain, on the one hand, is very sensitive. At the same time, it is also able to compensate quite a lot, and such subcortical lesions are frequently well covered and well compensated for quite some time, while cortical lesions do not show the same feature. Contrast enhancing lesions are highly, as I mentioned, a highly specific feature, and here you can see a dense lymphocytic infiltrate around blood vessel, and this is specimen comes from a famous case from the NIH, where it was shown that contrast enhancement in this area correlated with exactly the spot where you saw the dense inflammation. So if we see contrast enhancement, as you see in those slices, then you have features of the inflammatory disease activity. And such contrast enhancing lesions can have very different phenotypical features. They can be solid punctate, juxtacortical. They can have contrast enhancement right at the periphery, or as you see on the next slide, right next to the cortex. But what they have all in common is that the contrast between the normal tissue and the lesion is very clear. So it's very useful if you want to see how active a disease is, to use this particularly in the situation of the early diagnosis, or when patients have many T2 lesions and it's hard to detect a new T2 lesion, but contrast enhanced imaging will help you. Because the use of contrast has also been questioned in the past, but I will come to that in a minute. On these slides, you can see the high dynamic of MS. These are monthly scans from a phase 2 trial, and you can see in the blue circle a ring enhancing lesion that at the next month is no longer seen and shows a little shadow a month after. But on month 2, there are 2 other areas that show contrast enhancement. So this is highly dynamic, while you don't see any of these features on clinical grounds. This patient did not show any symptoms for these lesions. So it is very informative to have this available. Now we only use macrocyclic contrast agents. Before also linear gadolinium compounds were allowed, and they could, with those you could see depositions of gadolinium in the dentate nucleus of the cerebellum. But as you see here, with macrocyclic agents, this is no longer the case, and so I think we are in a very safe place with our contrast enhanced imaging. I show you also now how useful contrast enhanced imaging can be, because in this patient who was originally treated with beta interferon, you can see quite a few of hyper intense dots, but this becomes much clearer on the contrast enhanced image, because many of those little dots you would question whether these are really pathologic, but here you can see a high number of contrast enhanced lesions, and clearly the medication was not working. This patient had neutralizing antibodies, so it was very useful to see. And many times these contrast enhanced images make it clearer, as you can see from this systematic review, that it is much better to detect contrast enhanced lesions in comparison to new T2 lesions. Also, enlarging T2 lesions are quite can be quite difficult to see if the measurement technique is not perfect. Here you can see another feature. If you don't want to use contrast, you can use diffusion-weighted imaging, and you see in purple a chronic lesion, while you see above that lesion an acute lesion. This is the diffusion-weighted image, where it is very bright, like in a stroke situation, while the ADC map shows a reduced diffusion in this situation. So there is an acute inflammation with an aggressive inflammatory milieu causing these changes. While on the T1-weighted image, not much has happened, and on the T2-weighted image, on the flare image, you only see very faint or some hyperintensity, but not as clearly as on the diffusion-weighted image. So that's one other possibility to detect acute lesions, and we use this all the time because it can be done very quickly in less than 2 minutes, and you have some extra information. Here you can see imaging from 7 Tesla, which helps you to increase the susceptibility, so we can see veins much clearer, as you see here, and you can see the position of the lesions that many times have central veins. So this is again a highly specific feature, and probably will be introduced into the next diagnostic criteria of MS. So if you see such lesions around veins, this can be very useful if you are in doubt about whether this is truly MS or a non-specific lesion. For this purpose, susceptibility-weighted imaging is useful, and you can see such images here. Here we see a non-specific T2 lesion that shows no contrast enhancement, but a thick vein is running through the center of this lesion. So this makes it very likely that this is an inflammatory lesion of MS, and this kind of information you can get with this extra bit. We nowadays have the concept that besides acute inflammation in the form of contrast enhancement that is shown here, excuse me, with the yellow lesions and the blue lesions, you also have chronic inflammation around certain spots and certain lesions. This can be on the surface of the brain, particularly in long-standing MS, where you can see leptomeningeal follicles, but it can also be in the situation where you have chronically slowly expanding lesions that I will show. And if you have such features of some chronic inflammation going on besides acute inflammation, then of course there is a higher likelihood for progression and worsening of the disease, even in the absence of an acute relapse. And this has been the focus in recent years, to study whether you always need to develop an acute relapse to worsen, and indeed this is not the case, and so our understanding in that regard has advanced. So we have this concept of two different features of inflammation, and both need to be looked at and want to be treated as best as possible, or can be used for the prognostic assessment. So the acute inflammation we can much more easily detect, while the chronic inflammation has much more subtle features, is also not as frequent, but is quite important and will be an extension in the future of our trial. Here you can see such a slowly expanding lesion. It has a dark rim. This is an area where macrophages laden with iron cause the dark rim, and the slow expansion of this lesion is a typical feature of such lesions that I've mentioned. You can also see them on T1 or T2 weighted imaging, as in this movie. All this data comes from Vienna, and this data comes from the OPERA trials, demonstrate quite nicely, if you look frequently and with high accuracy, that such features are present in MS patients. And these lesions only in the situation of a large trial, we are really in the position to generate numbers that are sufficient to demonstrate the statistical significance, as it has been done here on T1 hypointense lesions, as well as on SWI susceptibility-weighted images. Here you can see typical features of these lesions. It is a black hole on the T1 weighted image. At the same time shows these black elements on the SWI, even more highlighted, and on the flare or T2 it cannot be differentiated from other lesions. You can see another lesion down here with a black rim that is also hyperintense, but not quite so hypo-intense on the T1 weighted image. So you can try to find these lesions that way, or you do follow-up imaging. As you can see here, this was done on a T1 weighted image, and areas that are green and yellowish that have not changed, and those who are very hot have changed in size, have become bigger, while the very cold colors, the blue colors, show that tissue has shrunk. And it's very interesting to see that these typical lesion locations show increased lesion sizes over 1 year, while right next to these lesions you can see atrophy developing in the corpus callosum. This is demonstrating to you the effect of a focal lesion also on the brain parenchyma right next to it, because the connections are being cut and damaged by such an expanding lesion. And that makes it very obvious why such slowly evolving in size increasing lesions have a bad impact on the clinical side. So what are the poor prognostic signs if you see it on clinical imaging as you do it with your patients that are being imaged at regular times? If there is at the first place a high T2 lesion load in a patient that doesn't have such a long disease duration, that of course demonstrates to you there has been high disease activity in the time span that you're overlooking. More than 2 gadolinium positive lesions are a poor sign because it demonstrates to you that this is a highly active situation. This is also correlating very well with neurofilament levels, for example. If you have very hypointense lesions, as I've shown in the beginning, this again is a poor prognostic indicator. So you want to watch and look at these patients in particular. If you find early indications of atrophy, which is not easy to identify visually, but can be done, for example, around the third ventricle when there is when the thalamus has developed some atrophy, or when the corpus callosum is thinner, this is also a poor prognostic sign. If there are strategic locations, like in the infratentorial space, or cortical lesions, or in the spinal cord, then of course the likelihood of a clinical correlating syndrome is very high. And in particular, patients who show up with several spinal cord lesions are quite worrisome, and you may want to pick the most effective therapy right away, particularly in those patients where there seems to be a specific predominance of such strategic lesions. So our trend has been in the past integrating such spatial topographic information coming from MRI and disease activity to sensitize ourselves for patients who are at higher risk to develop clinical disability early, and therefore be as active as possible with treatment with those candidates. This will generate automatically a much more solid-based view of your patients, and I think that is very useful. And ideally, we can nowadays reach a situation where these patients come to a very stable situation, and we can observe no evidence of disease activity at all levels in many patients, and fortunately only few patients remain very difficult. Focal spinal atrophy demonstrates to you that there has been a spinal cord inflammation and injury through an inflammatory lesion, and many times this is causing a permanent clinical syndrome, so this is also a poor prognostic sign. So I told you about the prognostic value of MRI. First of all, you need it to demonstrate dissemination in space and time, and with the help of CSF analysis, you will be able to early on determine whether the diagnosis of MS is given or not. But at the same time, you have prognostic information of what this patient looks like in terms of the future perspective. And that can be very helpful, particularly as the clinical information may vary from patient to patient. Some patient doesn't want to speak about symptoms, while others just do the opposite. And there you have at least the possibility to have some background information to get more information. So I think it's very useful to include the topographic distribution of lesions, not just the number and whether there's contrast enhancement or not, but exactly where the inflammation has hit the patient in the past, because this will give you a rationale and a way to view your patient individually, also for future perspectives. With this, I think I'm still within the time, at least my stopwatch is telling me so, And I want to thank you for your attention, and I would be very happy and inspired if we had questions concerning this topic. So thank you very much.